So, hello student, we'll begin with the medical coding CPT guideline for the musculoskeletal system. This system mainly deals with the muscle and then the skeleton, that is the bone injury. So, this particular guidelines are also divided into three parts. So, let's begin with the part 1. So whenever we deal with the new chapter, we must know how this chapter has been designed. So as far as the musculoskeletal system is concerned, it is formatted by the anatomic side. That is, you will have the heading head, neck, and then the spine, abdomen, shoulder, forearm, and the wrist, hand and fingers, pelvic and hip joint, femur. So these are the headings, and then if you see here that every heading has the subheading, that is incision, excision, introduction, removal, repair. So pretty much these subheadings are repeated for all these headings. So this you must know, so that once you understand how the this chapter is divided, then it is very easy for you to navigate this chapter. So this is a snapshot of the index that is there at the beginning of this particular section, and here you will see once again all the headings which are given in the red color, and then the blue color is subheadings, and this particular color coding you can see in the professional edition. So the topic which we are going to cover in this particular section is fracture care, wound exploration, trigger point injection, excision and repair, arthrocentesis, spine procedure, and then the scopist. And since we are dealing with the skeletal-muscular system, it will be arthroscopy, because scopy is nothing but the viewing of that particular system. If it is, we are going to see the colon, we call it as a colonoscopy, and here we are mainly dealing with the arthroscopy. As far as the fracture care, you must know different eponyms they are used for the fracture: the Cooley's fracture, the Smith fracture, Jones fracture, Salter and Harris Jucterian fracture, and Montague's fracture. So these are the eponym. You can just Google it and find out where do you see this particular fracture, because sometimes in the anatomy section they may ask where do you find a Cooley's fracture, or where do you find a Salter and Harris fracture. Now the first important topic is the fracture care, and whatever the guideline you will see in the fracture care, they are applied to all the bone fracture which you will see from the head to toe. So as far as the fracture care is concerned, we have the closed treatment, open treatment and percutaneous treatment. The closed treatment is basically means the fracture site is not surgically exposed, and there are three methods: without manipulation, when the bone is fractured but it has not moved from its original position, where we may require just to put the cast to stabilize that part, and with manipulation means when the bones must have moved from its original position, so we need to put the force and get them back into their position, and then we put the cast, and with or without traction. Sometimes we have to put the traction, that is the additional weight to get them into that natural line. So this is as far as the closed treatment is concerned. As far as the open treatment is concerned, the type of the fracture is mainly used when the fracture bone is surgically exposed. Surgically exposed is you will cut open the skin above the bone, and then you will do the treatment. And percutaneous skeleton fixation, it is neither open neither closed, but sometimes we put the pin across the fracture site and keep those the two fracture fragment together. So these are the various fracture treatment that you should know. Now in the book you will see this fracture guideline, but I will explain them point wise so that you will always remember. So what are the coding tips for the fracture? Don't go by the nature of the fracture, code only based on the type of the treatment. And then we have to identify that treatment. It could be the open, close or percutaneous. And second important thing is one must identify the fracture site and then lead to the appropriate code. That is, suppose if the fracture site is humerus or the radius ulna, I'll be looking in the upper extremities. If it is the femur and the tibiofibula, then I'll be looking for the lower extremities. So here your understanding of the bone is very, very important. So let us take an example. Patient having a closed fracture. Closed fracture means whenever the skin above the fracture bone is intact, that is called as a closed fracture. So whenever the patient is having closed fracture, provider done the open treatment. So maybe the bone was severely misplaced. The provider has surgically opened the skin and decided to align the bone, and he must have put the plate also. So that is called as a open treatment. So I will you code for the open treatment. Okay, so that is very important. And then the third important point is all services that appear in the musculoskeletal system section include the application and removal of the first cast, splint and the traction device. Okay, so these three are the very important points. Now let us take the example on this particular guideline. So the preoperative diagnosis is right scaphoid fracture, and the type of the procedure is open reduction and internal fixation of the right scaphoid fracture, and the description of the procedure is given. Sometimes during the exam, if you get the type of the procedure, then we may not go into the detail, but I would highly recommend to read the description, because there are certain other clues that you will get in this particular description. So in this case, what is important is 0.045 Krishnal wire was then used as a guide wire extending from the proximal pole of the scaphoid distal ward. The guide wire was positioned approximately and then measured. A 25 millimeter acute-track drill bit was drilled to 25 millimeter. A 25.5 millimeter screw was selected and inserted, and a rigid internal fixation was accomplished in this fashion. So this was visualized under OEC imaging device in multiple projection. The wound was irrigated and closed in layer. So what is the guideline? We don't look what is the nature of the fracture, we code it by the type of the treatment. Here the type of the treatment is open treatment, because it is given as an open reduction and internal fixation. And so whatever the codes are given, the first code is closed treatment. I'm not interested in that, because we see the nature of the the type of the treatment. So then 25628 is open treatment, and there also you have to be very particular in reading the site, and here it is a carpal scaphoid fracture, include the internal fixation, and second is also open treatment carpal bone fracture other than the carpal scaphoid. So you know the site is that specific, and there they have not even include the internal fixation. So my code will be 25628, and since it is done on the right side, I can put the modifier RT. Now let us take one more example. 2 weeks ago, Sam underwent an open repair of his lower femur due to traumatic fracture suffered while snow skiing. His leg is healing as expected, and no new treatment is required to the femur. Today he returns as planned for an application of the new long leg cast. The cast application is completed by the same physician who performed the surgery. How should today's service be reported? So they have told you to code for the today's service, and today's service is no way related with the fracture, because the fracture treatment happened during his last visit. Today he came for the application of the new long case cast, and you have all the code. So we will see all the code, put all the code, and if you see the code 29345, it talks about application of the long leg cast. And the code 29700, it is a removal of the bivalving Gauntel boot or body cast. Removal didn't happen, he came for the application, so we'll definitely require a code 29345. And here the modifier is very important. Who put the cast? The cast was put by the the cast application is completed by the same physician who performed the surgery. So that is very, very important. So after seeing all the answer, let us eliminate the wrong answer first. So if you see the answer B, it talks about the E&M service. So that is not the correct answer. If you see the answer C, it talks about the application as well as the removal. That didn't happen in our case. It was only the application that happened. So it is left with the two options. Now we left with the two options, that is option A and option D, and both have the same code but the modifier differs. So if you see the modifier 76, it talks about the repeat procedure or the service by the same physician. That didn't happen. It is definitely not a repeat procedure. And 58 says stage or related procedure. So this was a related procedure because it was related to the fracture femur, and that's why 58 is the more appropriate modifier, and that's why we will code 29345 and 58. The patient presents today for the close reduction of the nasal fracture. The depressed right nasal bone was elevated using the heavy reduction forceps, while the left nasal bone was pushed to the midline. This resulted in the good alignment of the external nasal dorsum. What CPT code reported for this procedure? Now see all the code. What is the kind of fracture here? So we need to underline the important word. So this is the close reduction of the nasal fracture. So if we see the code in that, the 21336 is the code for the open treatment, and 21325, that is the code A, is also for the open treatment. Our treatment is a close reduction, and we code the fracture depending upon the type of the treatment. So we will see here, this is the 320, not 310 by mistake. So we will require whether we can use this code. 315 is the code which says close treatment of the nasal bone fracture with manipulation. Did the manipulation happen? Yes, it did happen, because the right nasal bone was elevated using heavy reduction forceps, while the left nasal bone was pushed to the midline. This is the reduction or the manipulation. Without stabilization, did they give the stabilization? Now whenever we are stabilizing the fracture site, we are going to give a cast or the splint, and here there is no mention of the cast or the splint, so definitely the stabilization didn't happen. So we have all this point. Now we will zero down our answer. So after looking at all the code, 21315 is the correct answer, because it talks about the close treatment of the nasal bone fracture with a manipulation and without stabilization. So let us take one more example on fracture. A 22-year-old female sustained a dislocation of the right elbow with a medial epicondyle fracture while on vacation. The patient was placed under general anesthesia and the elbow was reduced and stable. The medial elbow was held in the appropriate position and was reduced into acceptable position and elevated to treat non-surgically. A long arm splint was applied. The patient is referred to an orthopedist when she returns to her home state in few days. What are the CPT code? Now whenever we are coding for the fracture, the type of the fracture, whether the manipulation has done, the stabilization has done, all those things we are going to consider. So this is clearly, it is the case of the, and even the site of the fracture. So we need to find out how the fracture has been treated. And if you see this, the fracture was treated non-surgically, that means it is a close fracture treatment. Then it was manipulated, because here you can clearly see the elbow was reduced and was stable. It was done under general anesthesia. That is also an important consideration. And then the splint has been given, because accepted position, elevated non-surgically, long-term splint was applied. So we will take all this information and we'll try to select the code. So if you see this open treatment, this will go away, because we do not have the open treatment. It is very clearly given. It is a closed treatment. So we will only focus on the closed treatment, and then we have to also close treatment of the site. The site is medial epicondylar fracture. So this is a humeral epicondylar fracture, medial or lateral, without manipulation. But in our case, the manipulation did happen, because, and then we need to check whether they include the stabilization or no. So the first code has been zeroed down, that is 24565. Let's move to the second code, and if we see all the option, the 24605 is the correct option, because it talks about the close treatment of the humeral, close treatment of the closed elbow dislocation without anesthesia, and that is without anesthesia. But 24605, it is a requiring anesthesia. So by considering all those points, the D is the correct answer. Now this is the operative report. You nowadays in the CPC exam, they are giving 10 operative reports, so you must know how to solve this. In that, you will have the pre-operative and the post-operative diagnosis. Here the pre-operative diagnosis is displaced impacted Cooley's fracture, left distal radius and ulna. So now by this you can make out that where does the Cooley's fracture happen, and it is left distal and radius and ulna. That is the part of the radius and ulna near the wrist. That is very important. Which is the distal part and which is the proximal part of the bone, one must know. And what is the procedure? Reduction with application of the external fixation system, left wrist fracture. This will also give us a clue how the fracture has been treated. So, and then we move to the procedure description. In the procedure description, it is mandatory for you to read the description very carefully, because sometimes you will get a lot of clues what has happened in this patient case. So under satisfactory general GA, the fracture was manipulated and CM arm image were checked. The left upper extremities were prepped, draped and usual steroid orthopedic fashion, and two small incisions were made over the second metacarpal, and after removing the soft tissue including the tendinous structure out of the way, drawing was carried out and the blunt tip pins were placed for the EBI external fixator. So now when you read this, many a time the confusion happens. We see the word incision and we feel this could be the case of the open treatment. But remember, we need to find out why these incisions were taken. And if you read the whole description, you will realize this small incisions is basically to fix the external fixation system. Okay, it is not to deal with the fracture treatment, but to fix the external fixation system. So this is the case of a fracture which is done by the close treatment, and they have done the reduction. That means the manipulation has happened and they have put the external fixation system. So these are the clue that we have. Now we need to check the answer. So we know that it is a close treatment, then we should know where is the site. So the open treatment, so 25607, that is the D option, we can eliminate. Then this is a percutaneous skeleton fixation of the radius fracture or the epiphyseal separation. Now in this case it is a percutaneous fixation, in our case it is the external fixation. So that 25606 also goes away. Now we need to check between 600 and 605. It is a close treatment of the distal radial fracture, example Cooley's or the Smith type, or epiphyseal separation include close treatment of the fracture of ulnar stallard when performed without manipulation. In our case, they have said the word reduction, that means the manipulation did happen. So I am going to zero down the code 25605. Now what is this code 20690? Application of the uniplane external fixation system, application of the multiplane external fixation system. Uniplane means all the screws are in one plane, and this is whether they have given, no. So you will have to find out how many screws they have put. Usually that is also one of the important clue, that number of the screws. If they are more than 3 to 4, it is usually a uniplane. But if they are more than 4 to 5, then usually they are in the multiplane. That is one of the hint you can use. So 25605 and 2 20690 because first is for the close treatment of the fracture with a manipulation and second is for the application of the uniplane. Okay, so the answer is B 25605 and 20690. So you can go through this rationale that will help you to read the things again better. And the only way to pass the CPC exam is do maximum questions so that you will get a practice of how to read the question, what is the important words, and how to zero down your option. So this is one more operative report. It talks about the displaced odontoid fracture. The post-operative diagnosis is the same. The procedure is open reduction of the odontoid fracture. It gives us a lot of clues that how the treatment of the fracture has been done because the type of the treatment decides our code. And what is odontoid? Odontoid is the process which is present in the on the C2 vertebra. The first is atlas and the second has this characteristic feature which is called as a odontoid processes. Now the patient was taken into the operating room and placed in the supine position on the operating room table. So here you will get a lot of clues which will give you some idea that how this fracture has been reduced. We already have that knowledge that it is an open reduction, but we need to check so this is a important word that the anterior neck was prepped and draped and the incision was made in the skin crease overlying the C4 C5 area. So this is also one important thing, and then we have to also see this Kirshner wire was advanced into the C2 body through the fracture line and into the odontoid processes. This was then drilled and 42 millimeter cannulated lag screw was advanced and C2 body advance through the C2 body into the odontoid processes. So it gives the clues that it is open reduction, then they have done the manipulation, then they have put the wires, but it was not a graft, the wires were put and the approach was the anterior approach. So let us see what we have the option. So let's eliminate the absolute wrong option. So the absolute wrong option is since it is open treatment, the closed treatment will be the absolute wrong option. So let us eliminate the option C because which is not the correct option because it talks about the closed treatment. Now we have the remaining option. Then 22505 it talks about the manipulation of the spine requiring anesthesia in the region. There is no manipulation. We are actually treating the fracture. So the two absolute wrong option we are going to eliminate, and then we will now check the 326 and 318. So after going through the code description, 22318 is the correct option because it does talk about the open treatment of the odontoid fracture. Then it does talk about the anterior approach and including the placement of the internal fixation without graft because we have put the wire, not the graft. So D is the correct. As the name suggests, this is a wound exploration. So we are exploring the wound for the removal of certain foreign bodies or any injury to the muscle and subcutaneous tissue. This is the wound which we are talking is a deep wound. Okay, so this is a very important consideration here. So let us go and learn about this topic. So this is the wound exploration. The code range is 20100 to 20103. I have summarized this guidelines into 3 points. First is identify whether the wound is penetrating wound like a gunshot or the sharp object. So if that is mentioned in your documentation, you can directly come to this code. Check whether the thoracotomy, that is cutting open of the chest, and the laparotomy, that is cutting open of the abdomen, done or not. If yes, code separately because that's an additional work, and if that has been done we need to mention that, and then eliminate the option with where other procedure like surgical exploration and enlargement of the wound, extension of the dissection, debridement, removal of the foreign body, ligation or coagulation has been done or not. So these are all the code for the wound exploration, and then you see the code 49000 that is for the exploratory laparotomy, 32100, it is for the thoracotomy, and 97602 is the removal of the devitalized tissue from the wound, non-selective debridement without anesthesia. So all these codes are important. Now we'll see how these guidelines are tested. Kindly read all the parenthetical note. This will be always the guideline for all the codes. So that will give you a lot of clues also to finalize your answer. So let us take one example. Patient suffered a penetrating knife wound to his back. The surgeon performed a wound exploration with the enlargement of the site, debridement and removal of the gravel from the site. The surgeon decided a laparotomy procedure was not necessary at this time. How would you report this procedure? So collect the important clue that the laparotomy procedure was not done. It is done, the wound is at his back and surgeon did the exploration and enlargement of the site. Now, since the laparotomy procedure is not performed, we can straight away eliminate answer A and B because it talks about the laparotomy procedure. We have just seen this code. Now we have only C and D. So let us see what's the answer. So the answer is 20102 because the code will be exploration of the penetrating wound, abdomen, flank and back. And in our case, the injury happened at the back. So we will zero down the answer C. Now let us take one more example. Michael, a 28-year-old, was involved in a brawl at Charlie's neighborhood bar and sustained a stab to the chest. Stab to the chest important because the site is also important. The patient was taken to ED via ambulance. The ED physician was concerned about the location of the penetrating wound and felt it is necessary to comprehensively explore the wound to ensure the vital organs and arteries were not injured. Thoracotomy exploration was carried out. The physician was able to explore and view the chest cavity, lungs and pleura and was satisfied none of these organs areas were impacted by the penetration. Chest muscle, fascia, subcutaneous and dermis were repaired in a layered fashion. Which procedure code best describe the encounter? Now let us see the area is chest and the laparotomy was thoracotomy and exploration was carried out. So these are the two important factors in our case. So let us see what's the answer. So here after going through all the options, A is the correct option because this is the case of the thoracotomy exploration. So if you see the code 32100, it talks about the thoracotomy with exploration. So they have cut open the chest and they have done the exploration also. So that one code suffice both the cutting and exploration. So we will use only that code. And the remaining code which talks only about the exploration, they are not the correct code. So, and kindly always pay attention to the parenthetical note because they also give a lot of clues to you. So this is my last slide of the part 1 and then we'll continue with the part 2, 3, 4 and 5 for the musculoskeletal system.